Are your ad campaigns lighting up the dashboard, but not the pipeline? That's bullspend, and marketers are calling it out in Dashboard Confessions.
My boss asked for results, so I opened my dashboard for the only positive-sounding metric I had: impressions.
Cut the bull spend. See revenue, not just reach. LinkedIn delivers the highest return on ad spend of major ad networks. Advertise on LinkedIn. Spend $250 on your first campaign and get a $250 credit. Go to linkedin.com/campaign. Terms and conditions apply.
Hey everyone, Chris here from MedPrep to Go, and I wanted to tell you about our MedPrep to Go Step 3 review podcast that features over 90 episodes and 40 hours of high-yield content from Dr. Ted O'Connell and Dr. Raj Dasgupta. This is a premium podcast that has already helped over 100 students pass their exam. You can learn more and subscribe at medprep2go.com. Hey everyone, Chris here from MedPrep to Go, and welcome to another episode of our USMLE Step 2 Questions podcast. In this episode, I'll be reading 3 orthopedics questions from our online Qbank, and as always, you can read these questions and more at medprep2go.com. And now we will get started with question 1, Orthopedics 4. A 78-year-old woman is brought to the emergency department after falling at home. She reports immediate left hip pain and is unable to bear weight. Her medical history includes hypertension and osteoporosis. Vital signs are within normal limits. Physical examination shows the left leg is shortened and externally rotated. Radiographs reveal a displaced fracture through the femoral neck. Which of the following is the most appropriate definitive management? Is it A, closed reduction and casting? B, hemiarthroplasty? C, non-operative management with early mobilization? D, open reduction and internal fixation? Or E, total hip arthroplasty? And the correct answer is B, hemiarthroplasty. Displaced femoral neck fractures in elderly patients disrupt the blood supply to the femoral head via the medial femoral circumflex artery, placing the patient at high risk for avascular necrosis and non-union. Because bone healing potential is limited in older adults, hemiarthroplasty provides the best functional outcome and allows early mobilization. Answer choice A, closed reduction and casting, is incorrect. Casting does not provide adequate stabilization and leads to prolonged immobility and increased risk of complications such as deep vein thrombosis and pneumonia. Answer choice C, non-operative management with early mobilization, is incorrect. Non-operative management is associated with high morbidity and mortality in displaced hip fractures. Answer choice D, open reduction and internal fixation, is incorrect. Open reduction and internal fixation, ORIF, is preferred in younger patients with non-displaced fractures where femoral head preservation is feasible. Answer choice E, total hip arthroplasty, is incorrect. Total hip replacement may be considered in select, highly active elderly patients, but is not first line for most displaced femoral neck fractures. Key learning point. Displaced femoral neck fractures in elderly patients are treated with hemiarthroplasty due to a high risk of avascular necrosis. Question 2, Orthopedics 5. A 24-year-old male is brought to the emergency department following a motorcycle accident. He is found to have a closed comminuted fracture of the right midshaft tibia. The fracture is stabilized with a long leg splint. 4 hours later, the patient reports excruciating pain in his right leg that is refractory to the intravenous morphine. On physical examination, the right calf is tense and exquisitely tender to palpation. There is significant pain triggered by passive extension of the great toe. Sensation is decreased in the first dorsal webbed space of the right foot. Distal pulses are 2+ and equal bilaterally. Which of the following is the most appropriate next step in management? Is it A, application of an ice pack and elevation of the limb? B, Doppler ultrasound of the lower extremity? C, emergent surgical fasciotomy? D, measurement of compartment pressures? Or E, removal of the splint and restrictive dressings? And the correct answer is E, removal of the splint and restrictive dressings. This patient is exhibiting the classic signs of acute compartment syndrome, ACS, which includes pain out of proportion to the injury, a tense wood-like feel to the limb, and pain with passive stretch. In the context of a recent fracture and splinting, the first step in management is to remove any external sources of pressure, such as tight splints, casts, or dressings. This simple maneuver can significantly reduce intracompartmental pressure. If symptoms do not immediately improve after removing the dressings, then further invasive measures or surgery are indicated. Answer choice A, application of an ice pack and elevation of the limb, is incorrect. While elevation is standard for most orthopedic injuries, in suspected ACS, the limb should be kept at heart level. Elevating the limb can decrease arterial inflow and further compromise perfusion pressure. Perfusion pressure equals mean arterial pressure minus compartmental pressure. Answer choice B, Doppler ultrasound of the lower extremity, is incorrect. This is used to rule out deep vein thrombosis, or DVT. While DVT can cause leg swelling and pain, the acute trauma, pain with passive stretch, and sensory deficits in this patient are much more indicative of ACS. Answer choice C, emergent surgical fasciotomy, is incorrect. While fasciotomy is the definitive treatment of ACS, the initial bedside management should include removing restrictive dressings. If the diagnosis remains certain, or if pressure measurements remain elevated after dressing removal, the patient should then proceed to the operating room. Answer choice D, measurement of compartment pressures, is incorrect. ACS is primarily a clinical diagnosis. Pressure measurements are generally reserved for patients who are obtunded, have equivocal physical exam findings, or are otherwise unable to provide a reliable history. In a conscious patient with clear red flag symptoms, the diagnosis is clinical. Key learning point. The initial management of suspected acute compartment syndrome involves the immediate removal of restrictive dressings or casts and keeping the limb at heart level. Following these steps, if clinical suspicion remains high or pressures are objectively elevated, emergent surgical fasciotomy is required. Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics. Hey everyone, Chris here from MedPrep2Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We'd greatly appreciate it as we try to spread the word about MedPrep2Go and keep medical education accessible and affordable. Question 3, Orthopedics 6. A 22-year-old man presents to the urgent care clinic after falling onto his outstretched right hand during a basketball game. He reports immediate pain on the radial side of his wrist, and past medical history is negative. On physical examination, there is no obvious deformity or swelling. However, there is a significant tenderness to palpation within the anatomical snuff box. Range of motion of the wrist is limited by pain, particularly with radial deviation. Initial postero-anterior, lateral, and scaphoid view radiographs of the wrist show no evidence of a fracture. Which of the following is the most appropriate next step in management? Is it A, computed tomography of the wrist, B, diagnostic arthroscopy, C, open reduction and internal fixation, D, reassurance and symptomatic treatment with ibuprofen, or E, thumb spica splinting and repeat imaging in 2 weeks? And the correct answer is E, thumb spica splinting and repeat imaging in 2 weeks. This patient has a clinical presentation highly suggestive of a scaphoid fracture despite negative initial radiographs. The scaphoid is the most commonly fractured carpal bone, typically occurring from a fall on an outstretched hand. Initial X-rays have a low sensitivity for non-displaced scaphoid fractures, which may not become radiographically apparent until bone resorption occurs at the fracture site 7 to 14 days later. The standard of care for a patient with snuff box tenderness and negative initial imaging is immobilization in a thumb spica splint, followed by repeat clinical evaluation and X-rays in 10 to 14 days. Alternatively, advanced imaging like MRI could be performed if an immediate diagnosis is required. Answer choice A, computed tomography of the wrist, is incorrect. While CT is excellent for evaluating fractured union or displacement, MRI is the preferred advanced imaging modality for detecting occult scaphoid fractures acutely. However, the most cost-effective and common strategy is splinting and delayed re-imaging. Answer choice B, diagnostic arthroscopy, is incorrect. Arthroscopy is an invasive procedure used for ligamentous injuries or unexplained chronic wrist pain, but it is not a first-line diagnostic tool for an acute suspected fracture. Answer choice C, open reduction and internal fixation, is incorrect. Surgical intervention is reserved for displaced fractures greater than 1 mm, certain fracture locations, like the proximal pole, or non-unions. It is not indicated for a suspected fracture that has not yet been visualized. Answer choice D, reassurance and symptomatic treatment with ibuprofen, is incorrect. Because the scaphoid has a tenuous blood supply via retrograde flow from the radial artery, missing a fracture can lead to avascular necrosis and non-union. Conservative wait-and-see management without immobilization is contraindicated. Key learning point. In the setting of a fall on an outstretched hand and anatomical snuffbox tenderness, a scaphoid fracture must be suspected even if initial radiographs are negative. The most appropriate next step is immobilization and a thumb spica splint and repeat imaging in 10 to 14 days to rule out an occult fracture and prevent complications like avascular necrosis. And that will conclude this episode of our USMLE Step 2 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 2 questions at medprep2go.com. Happy studying! Hey everyone, Chris here from MedPrep2Go, and I want to take a quick break to announce that our first course is now live. Comprehensive Endocrinology is a video series with Dr. Raj Dasgupta that features 9 hours of content in 8 modules. This course is useful for learning endocrinology for internal medicine, family medicine, USMLE Step 3, and COMLEX Level 3. And this content is exclusive to the video series and won't be available on any of our podcasts. Keeping with our philosophy of making medical education affordable and accessible, this course is available for just $10 a month or $20 for a year. So check it out now and start learning at medprep2go.com. And stay tuned for more courses coming later this year. Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 2 Bundle podcast, which gets you all of the Step 2 secrets and our Step 2 Questions podcast combined and ad-free. You'll also get early access to all of our Step 2 Questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com.